Today we're looking at arboviruses. So these are zoonotic viruses which are transmittable from animals, arthropods, vertebrates to man. Many are transmitted by means of an infected blood-sucking arthropod vector, arthropod-borne arboviruses. Others can be transmitted by inhalation or conjunctival contact with infected excretions, or by direct contact with infected animals, such as rabies. Constant vigilance and surveillance are important components in reducing the public health impact of the disease. The virus replicates in the vector, but usually it does not harm it. In the mosquito-borne diseases, the virus establishes a persistent infection in the salivary glands, and there is sufficient virus in the saliva to infect another host during feeding. Each virus usually only grows in a limited number of mosquito species. The natural habitat of the vector, which is rural or around dwellings, its diurnal activity patterns and its preferred targets for blood meal affect the transmission pattern of disease. Many vectors are only active during part of the year, as this will affect the seasonal incidence of the disease. Insect vectors may overwinter as eggs. In this case, the virus must either be transmitted transvirally, which happens in some cases, or survive the winter in a vertebrate host and infect the vector for the following year. So, the virus is used to maintain a vertebrate host. There is often a persistent viremia, and the host can act as a long-term reservoir. In many cases, the reservoir host is not severely affected by the viral infection. If the vertebrate reservoir is migratory, then this will affect the timing of the infection in a particular locale. Also, if the virus is transmitted to another animal or its normal host, viremia is low or transient, there's a little chance of the infected animal being able to pass the virus enough to a blood-sucking arthropod to establish an infection. In this case, the animal is said to be a dead-end host. Man is a dead-end host in the case of most arboviruses. Exceptions include yellow fever and dengue fever. So methods of prevention include surveillance, vector control, public education about and reducing breeding sites for vectors, and reducing exposure to vectors by wearing suitable clothing, using insect repellents, timing activities for low risk time of day, and use of vaccines in the few cases where it's available. There are several types of life cycles, but many arboviruses have a salvitic life cycle, also have an urban life cycle. Salvitic, known also as a jungle cycle, the virus cycles between an arthropod and a mammalian host, with man usually a dead-end host infected by the arthropod. And for the urban cycle, in this, the virus cycles between man and arthropod species. There's an urban cycle for yellow fever and dengue fever. Both of these also have a salvitic fungal cycle. If there's an urban cycle, using window screens, bed nets to prevent access of mosquitoes to viremic patients can reduce transmission. Diseases caused by arboviruses include encephalitis, febrile diseases sometimes associated with rash, hemorrhagic fevers. There is some overlap of symptoms between various virus types. For example, viruses are not usually classed as encephalitis viruses, which can cause central nervous system symptoms. More than 100 arboviruses are known to affect man. Disease outbreaks caused by arboviruses are sporadic and unpredictable. Usually, infection is followed by replication endothelial cells and macrophages, monocyte lineage cells. Frequently, these infections are associated with flu-like symptoms, since these RNA viruses are good inducers of interferon. Also, the infection stops here, but it can produce enough virus or for secondary viremia, which can then cause a major infection of target organs of the brains and endothelial cells and livers. Which organs are targeted depends on the tropism of the virus. Access to the brain tends to be via infection of endothelial cells in the blood vessel supplying the brain. Recovery involves the cell-mediated immune system. The arboviruses are generally good inducers of interferon, which may partially explain early influenza-like symptoms common to many of these viruses, such as fever, headache, fatigue, and myalgia. Antibodies can be important in controlling the secondary viremia limiting disease. Diagnosis is difficult because many other agents cause similar symptoms. Arbovirus is usually confirmed by immunological methods, such as complement fixation, ELISA, immunofluorescence assay, or by polymerase chain reaction of the viral nucleic acid. The tests are usually done in a state laboratory or at the Centre of Disease Control. Awareness of an arbovirus associated disease in a particular area enables risk reduction procedures to be put in place, such as vector control, insect repellents, protective clothing, change in human activity patterns, and Resistance to arboviruses is mediated by antibodies, and recovery involves the cell-mediated immune system. The reservoir for lacrosse virus is small mammals, chipmunks, and squirrels, and the virus is transmitted by mosquitoes, Aedes aegypti, Eastertrochial mosquito. Humans are dead-end hosts and do not develop a sufficiently high viremia to infect a mosquito. The incubation period is 1 to 2 weeks after a bite by an infected mosquito. Symptoms include fever, headache, nausea, lethargy. Children more often develop symptoms than adults and are more prone to neuroinvasive disease, resulting in seizures, morbidity, and fatality, although severe neuroinvasive disease may result in repeated seizures, partial paralysis, and neurobehavioral changes. The elderly are most severely affected by a St. Louis encephalitis virus since they often have weaker immune systems. The reservoir is birds and the virus is transmitted by mosquitoes if humans is a dead-end host. This virus can have an urban cycle as well as a sylvatic cycle. Infections occur in the northern part of the United States in the late summer and early fall, but in the south, infections occur all year. In many cases of SLV infection, mild infections occur without apparent symptoms other than fever and headache. In more severe cases, there are high fever, neck stiffness, stupor, disorientation, coma, tremors, occasional convulsions, which occur mainly in infants, and spastic paralysis, but not really flaccid. There's also Eastern equine encephalitis, which occurs in birds and is transmitted by mosquitoes. So this Cusieta melanura mosquitoes transit the virus between birds. A variety of mosquito species transmit the virus from birds to humans and other mammals. Humans in the horsey are dead-end hosts. So many cases result in mild flu-like symptoms or no symptoms, and the children are more likely to have more severe clinical symptoms than adults. The incubation period is about 4 to 10 days. People under 15 or older than 50 are more likely to have severe symptoms. Disease that does not involve the brain is systemic and results in chills, fever, muscle and joint pain, and a general feeling of malaise. The symptoms resolve in a few weeks. The encephalitic form involving the central nervous system is somewhat different according to age. In infants, the disease is manifested abruptly, while older children exhibit symptoms of systemic disease first. Symptoms of the encephalitic disease include headache, fever, sleepiness, irritability, anorexia, nausea, diarrhea, cyanosis, convulsions, and coma. Moving on to West Nile encephalitis. So this is closely related to St. Louis encephalitis and was found in Africa, West Asia, Western Europe, and the Middle East. So most people become infected, show no symptoms, and mount a successful immune attack against the virus. Most of the remainder, 1 in 5 infected people, have flu-like symptoms, fever, headache, and general malaise, with an incubation period of 3 to 14 days. Sometimes there's a swelling of the lymph glands, which is known as lymphadenopathy, and there may also be a rash. In less than 1% of patients, the infection is life-threatening as a result of encephalitis or meningitis. The initial symptoms are high fever, headache, stiff neck, and these are followed by confusion, tremors, convulsions, paralysis, coma, and death in some cases. There's also Japanese encephalitis virus. So this is a mosquito-borne Culex tapetomycosis and other Culex species disease spread by Japanese encephalitis virus. It is not found in North America, but travelers to rural areas of South and East Asia may become infected. In temperate areas, the level of infected mosquitoes and GI virus disease is highest in the summer months, while in tropical areas, highest incidence is associated with rainy season. This infects pigs and birds, while humans are dead-end hosts. Most people who are infected by JE virus show no symptoms, but in 1% of infected people, severe symptoms may arise after an incubation time of 5 days to 2 weeks. The initial symptoms are fever, headache, nausea, which are followed by neurological symptoms such as weakness, movement disorders, seizures, which usually occur in children. When the infection causes encephalitis, the mortality rate is 20 to 30%, and 30% of survivors will continue to have neurobiological and psychiatric problems. Treatment is supported, but there's a good vaccine which should be considered by people visiting areas where JE virus is endemic. But this vaccine is licensed in the United States and can be given to people over the age of 2 months. So there's also Colorado tick fever, which is part of the reovirus family. This occurs in the Rocky Mountain states or above 44,000 feet. It's a mild disease resulting in fever, headache, myalgia, and rash, sore throat, and nausea. After an incubation period of 1 to 2 weeks, fatigue may last for a few weeks after other symptoms resolve. In very rare cases, there may be central nervous system involvement resulting in confusion, while the disease is really life-threatening. The virus is transmitted by ticks and is mostly seen in the summer, when contact with ticks is the most common. And for diagnosis, a physician must consider the much more serious Rocky Mountain spotted fever, which is known as the Tetzel disease, which may also have similar initial symptoms and be treated promptly. There is no specific treatment for this disease other than supportive care. Chikungunya virus is a single positive strand RNA virus in the alpha virus family of the Rotordaviridae. It is spread rapidly around the world. Chikungunya means that which bends up in East African Makonde language, describing the contorted posture assumed by people affected as a result of severe joint pain and nephritic symptoms of the disease. Chikungunya and Arboviral virus fever is usually found in warmer regions of Africa and Asia, with some incidents in Europe and other areas in post-endemic areas. The vectors of Chikungunya and Arboviral virus are two mosquito species, Aedes aegypti and Aedes albopictus. The virus can be spread by infected blood and rarely in utero. The newborn can be also infected from the mother at the time of delivery. About 3 to 7 days after infection, most patients experience fever over 39 degrees Celsius, 102 Fahrenheit, polyarthralgia, which is joint pain, sometimes some joint swelling. Other symptoms include headache, myalgia, conjunctivitis, arthritis, nausea, maculopapular rash. In the laboratory, there's also lymphopenia, thrombocytopenia, which is a low platelet count, high creatinine and high hepatic transaminases may be observed. Most symptoms are usually mild and resolve within a week, although polyarthralgia may exist. Some patients, however, experience more severe disease, including infants infected at birth, older people, and patients with chronic conditions. Rare complications include relapse or rheumatological symptoms, and joint pain may last for years. Chikungunya and Arboviral infection is rarely fatal as occurring in older patients. There is no vaccine and no specific treatment other than supportive care. Chikungunya can cause a fatal encephalitis. So there have been outbreaks previously in 2005 and over 300,000 people were infected. Although symptoms are usually mild, there were rare cases in which the central nervous system was involved and some were fatal, particularly in newborns and patients over 65. So in newborns, the rate was 187 per 100,000, people over 65 was 1,000. So many surviving patients also have long-term neurological problems. Dengue virus is part of the Flavivirus family. So dengue fever is the most common arthropod-borne human disease of over 400 million cases, increasing worldwide each year. Transmission is very rare in the United States, but common in Puerto Rico and other Caribbean islands. Some people have no symptoms of infection, yet are still able to pass on the virus. The virus has been transmitted by organ transplants, blood transfusion, possibly from mother to fetus. The natural hosts of dengue virus are monkeys and man and mosquitoes, mostly Aedes aegypti, but also by Aedes albopictus are the vector. Dengue virus has an urban and jungle cycle. There are 4 serotypes of dengue virus, which circulate in Asia, Africa, and Americas. Dengue is the most common arthropod-borne human disease and one of the most rapidly increasing diseases in the tropics. It occurs worldwide up to 400 million cases per year. Every year there are cases of dengue fever imported by travellers in the United States. Usually illness is 1 to 8 days after infection, and IgM antibody may not be present some month later. So you have acute onset symptoms which last about a week, which include high-grade fever, headache, rash, retroorbital pain, myalgia, arthralgia, maculopapular rash sometimes, and a change in your taste sensation sometimes. There's also mild bleeding from the nose and gums and easy bruising. Bone pain as well. That's why it's known as breakbone fever. So in these ways, dengue can be clinically indistinguishable from influenza, measles, or rubella. The infection can sometimes progress to encephalitis, encephalopathy. The symptoms of dengue are usually milder in children compared to adults. During the convalescence period, there may be prolonged weakness and anorexia. So looking at the treatment, there is no vaccine, and treatment is supportive. And dengue hemorrhagic fever, this is potentially a deadly complication of dengue and is most severe in children under 15 years of age. So globally, there are several 100,000 cases per year. This appears to be an immunopathological consequence of an infection of a person who has already developed immunity to one serotype of dengue virus or a virus of another serotype, although the mechanism is not fully understood. It may well involve an immune enhancement whereby there is increased uptake of virus coated with non-neutralizing antibody, which is developed during an early infection of a different serotype, into macrophages via the Fc receptor. The virus replicates in macrophages, results in increased viral load. In addition, macrophages become activated and release inflammatory cytokines. The immune enhancement by non-neutralizing antibody complicates prospects for vaccine development. The disease is most severe in children. Moreover, the presence of maternal antibody in infants may result in dengue hemorrhagic fever, even in a first infection of dengue virus. So in dengue hemorrhagic fever, increased vascular permeability is a major problem. So the initial symptoms during the stages of dengue hemorrhagic fever are those similar to classical dengue. However, after a week or so, as the fever subsides, the patient displays various symptoms such as restlessness, lethargy, persistent nausea, signs of circulatory failure, severe abdominal pain, breathing difficulties, skin issues, skin hemorrhages, petechia, purpura, or ecchymoses. Patients, this is followed by thrombocytopenia, hemoconcentration resulting from leakage of plasma from the circulatory system into the peritoneum and pleural cavity. The patients who develop these symptoms are in profound circulatory shock, in this case known as Dengue short syndrome, which can rapidly lead to death. Signs of Dengue short syndrome are cold, clammy skin, rapid weak pulse, narrowing of pulse pressure, and hypotension, low blood pressure. So if the patients with hemorrhagic fever are given suitable supportive treatment, especially fluid replacement and rest, the mortality rate is low, ranging from 2 to 5%, but if it's left untreated, the mortality may be very high, as high as 50%. The keys to survival of the patient is early diagnosis, and it is recommended that patients are thought to have dengue should be given acetaminophen preparations rather than aspirin, because the anticoagulant effects of the latter may aggravate the bleeding tendency associated with dengue infection. Yellow fever, hemorrhagic fever. So this is part of the Flavivirus family. This is a disease that is found only in Africa and South America. In South America, the disease is sporadic and occurs in forested areas. In Africa, yellow fever occurs mostly in the rainy season in the west and central areas of the continent. This disease is transmitted by Anab mosquitoes. Natural hosts of the virus include monkeys and man, as an urban and sylvatic cycle. Most people infected with the yellow fever virus have no illness or only mild illness, but some people develop symptoms after an incubation period that is typically 3 to 6 days. Mild illness includes fever, chills, severe headache, back pain, malaise, fatigue, nausea, and vomiting. So most patients improve after initial presentation. However, after a brief remission of hours to a day, about 15% of patients develop more severe symptoms. So this severe systemic disease is characterized by hemorrhages, degeneration of the liver, kidney and heart, and failure of multiple organs. The case fatality rate to be 50%. There is no specific treatment, but there's an effective vaccine attenuated to strain called 17 VNR. There are sometimes mild effects, headache, malaise of the vaccine within days of administration, and a few recipients, less than 5%, but there have been reports of severe illness, fever, hepatitis, multiple organ failure, and 7 patients in the past few years. Zika virus, Flavivirus family. So Zika virus is named after a place in Uganda, the Zika forest, where it was initially identified. This was identified in previous 1900s as a small icosahedral positive strand RNA virus in a Flavivirus family that is called recent widespread alarm. There were small outbreaks of Zika virus infection for decades in Africa and Asia. The virus spread to Micronesia over the years. In 2014, an outbreak of Zika virus infections occurred first in Easter Island and on South American mainland, particularly Brazil. The occurrence of Zika virus in Brazil was correlated to a large increase in infant microcephaly, in which an infant is born with an abnormally small head and then completely developed a brain at rouge. It is thought that infection or the pregnant mother with the virus is the cause of the abnormal fetal development. In addition, Zika virus infection may result in some cases of Guillain-Barré in adults. Yeah, I mean, I've 203 cases in Florida and Texas as a result of mosquito bites, and 76 cases contracted by other means such as sexual intercourse or congenital infection. Many more cases have also been involved and identified in the United States territories, such as particularly Puerto Rico. So most people do not show any symptoms of Zika virus infection, but about 20% will experience some mild symptoms and may last up to a week. These include exanthem rash, fever, conjunctivitis, headache, arthralgia, myalgia, and myalgia. So, looking at the diagnosis now. There are specialised tests available to distinguish Zika from other viral infections that cause similar symptoms, including dengue and chikungunya, as we mentioned in previous slides. These tests include the reverse transcriptase PCR, which detects virus RNA in the blood. There are also antibody tests to detect antiviral IgM. Neutralizing antibodies usually arise about a week after infection. People who experience symptoms that have travelled to an area where Zika outbreaks have occurred, such as South and Central America, should consult a healthcare provider. The virus usually persists in the blood for a week or more and can be spread by mosquitoes to another person. Zika virus, like dengue and chikungunya, is mostly transmitted by mosquito bites, usually by the Aedes species of mosquitoes, Aedes aegypti and Aedes albopictus. Therefore, it is likely to spread to all areas of North America where the mosquitoes are found. There are other rarer routes of transmission that occur as well. There have also been reports of sexual transmission in the United States previously as well. So in the case of sexual transmission, Tahiti's semen and urine of the infected male contained the virus but was not detected in his blood. Zika virus has also been found in saliva, although whether it can be spread by kissing is debatable. The virus can be spread by blood transmission from infected person. Mother to child transmission is also occurred, and this is a rare and probably occurs at the time of delivery. There is no evidence at present for transmission via breast milk. Looking at the treatment now, treatment of mild symptoms is supportive, including drinking fluids to prevent dehydration using an analgesic such as acetaminophen. Non-steroidal anti-inflammatory drugs and aspirin should not be taken. The best way of avoiding a Zika infection is to avoid mosquito bites. This can be done by using body covering clothing, wearing permethrin treated clothes, sleeping under mosquito nets, or using insect repellents such as DET or an AB. Probably the most effective short-term response to the wave of Zika virus infections will be mosquito control. There is no anti-Zika vaccine, although it is hoped there should be one in the future. Another possible avenue of treatment of pregnant mothers is monoclonal anti-Zika antibodies, which will take a much shorter time to develop than a vaccine. So Zika outbreaks have been reported from various African countries, Southeast Asia and Pacific Islands. It's also been reported from Brazil, possibly arriving when infected person attending the World Cup previously, and when that happened. The virus is spread to other South American countries, Central America, Mexico and the Caribbean, including Puerto Rico and the US Virgin Islands. It has also been reported from Cape Verde, an island on the northwest African coast. Cases have also been found in the United States and people returning from South America. It is likely that the virus will spread to all areas of the United States where the mosquito vectors are present. Zika outbreaks have been reported from some African countries, Southeast Asia and some Pacific Islands, as previously mentioned. So, looking at this a bit further, so I did mention about the Brazil World Cup, etc., and how that was spread back in 2014, I think it was 15 the World Cup was. There's also a Cape Verde. So you also have microcephaly, where most people experience no or mild symptoms of a Zika infection. There's considerable concern about the effect of the infection during pregnancy. There have been many reports of an increase in microcephaly in South American countries, and these have coincided with Zika virus epidemic. Originally, only a small case number of microcephaly cases should be identifiable Zika virus infection. However, more recent studies show RT-PCR that most cases of microcephaly, all the infants were infected by a virus. Also, other viruses, including cytomegalovirus and chikungunya, can result in aberrant brain and cranial development. Microcephaly, small heads, are a rare condition. So previously, it was only reported in Brazil a few years, but since the Zika virus outbreak began, there have been thousands of cases. Some indeed, perhaps the majority of these cases may be false positives, since there are other reasons that children are born with small heads, including, as noted above, other viral infections. However, it is clear that infants infected in utero by Zika do develop microcephaly. Unfortunately, now appears that complications in infant can occur if the pregnant mother is infected at any time in pregnancy. Some fetuses have died when mothers were infected late in pregnancy, 25 to 32 weeks, and exhibited brain calcifications. Microcephalic infants, besides having a small head and undeveloped brain, can exhibit seizures, loss of vision and blindness, hearing loss, poor balance, learning disabilities, and developmental delays. Microcephaly can be diagnosed in utero using ultrasound. It cannot be cured. There is no standard protocol for treatment. Some babies with a mild form of microcephaly have no problems, however, for many there will be lifelong disabilities, including blindness. Poor babies, to be honest.